Today we're going to talk about patient-driven protocols, or PDPs. Now you may also hear them called therapist-driven protocols. We've changed the name because they should be patient-focused. The days of when a respiratory care practitioner was told what to do and what was expected to do it are basically gone. We no longer do therapy just because the physician has ordered it. So today, in all respiratory schools, students are routinely challenged with various types of questions. We ask what signs and symptoms are manifested by the patient, what respiratory care diagnostic procedure should be implemented, what treatment modality might be helpful for this patient? How is the effectiveness of the therapy evaluated? And what should be done if the selected procedure and treatments do not work? This is where patient-driven protocols come into play. They are an integral part of respiratory care health services. According to the American Association for Respiratory Care, the purpose of respiratory PDPs are to deliver individualized diagnostic and therapeutic respiratory care to patients, assist the physician with evaluating patients' respiratory care needs, optimizing the allocation of respiratory care services, determine the indications for respiratory therapy and the appropriate modalities for providing high-quality, cost-effective care that improves patient outcomes and decreases length of stay, and to empower respiratory care practitioners to allocate care using sign and symptom-based algorithms for respiratory treatment. So using a patient-driven protocol gives you, the respiratory care practitioner, the authority to gather clinical information related to your patient's respiratory status, make an assessment of that clinical data that you've collected, and then start, increase, decrease, or discontinue certain respiratory therapies on a moment-to-moment basis. Now, while we are doing this, keep in mind that the therapist and the physician are working together. So the physician is always in the loop. Patient-driven protocols are set up by a committee where physicians are involved and represented. And we keep that physician, the ordering physician, in the loop. Therapy can be quickly modified in response to specific and immediate needs of your patient. So respiratory protocols significantly improve respiratory therapy outcomes, and they appreciably lower therapy costs. We do not give therapies that are unnecessary or unneeded to patients. Now, the knowledge base that's needed to have a successful PDP program is that you, the therapist, have to understand what is happening in the patient's lungs and how the lungs are being affected. Understand the pathophysiology of the mechanisms that are activated within the body and within the lungs. What do those symptoms and signs look like? That is the clinical manifestation. And what treatment modalities can we use to correct that problem? Now, the therapist's role is to systematically gather clinical information. You have to assess your patient and gather the information that is needed. Then you formulate an assessment. What is it that I need to assess? Based upon that assessment, what is the optimal treatment for the patient and for the disease process that is presenting? And finally, you need to document all of this in a clear and precise manner so that everyone can follow what you're doing, what the goals are, and what the outcomes are. Now, most protocols are written in flowcharts. And if you've never learned about flowcharts, this is your introduction to flowcharts. All of the little symbols that are on a flowchart actually mean something. If it is an oval, that is a start or end point in a chart. Arrows or lines connect and show relationship between the representative shapes. It helps to guide you to where you're going next. A parallelogram represents input or output. So you need to have information gathering at this point. Rectangles represent a process, and a diamond indicates that a decision is made at that point. When you look at most protocols, this is what they look like. And it can be very intimidating when you look at a protocol that is written out as a flowchart. But you can see up here where we say the oval, airway clearance is ordered. So we're going to move to the next spot, and it's a diamond. There's a decision that needs to be made here. Is there a secretion clearance problem? Yes or no? If the answer is no, the treatment is not indicated, notify the physician, and that's the end. But if there is a secretion problem, are they a known responder? Meaning, do we know this patient? Do we know that they will be able to cough up secretions? If that is a yes, do they perform it correctly? And if they do, the answer is yes, then we are to a rectangle. Remember, a rectangle is a process, and that process is to continue the therapy. Now, I'm not going to go through this entire algorithm, but you can see how following an algorithm goes. And the input-output part, you'll see there are 3 parallelograms here. Depending on where you end up, you may need to put more information into the decision makings. Nowadays, we have made the process a little bit more streamlined. Now we are using assessments that give us points. When you look at this assessment, there are 2 parts to it. There is the chart assessment, where you're looking at the chart, and there is the patient assessment, where you are assessing the patient. So I'm going to look at the chart and say, under pulmonary status, do they have a smoking history? And if they do, let's say they smoke more than 1 pack per day, then I'm going to put an X in this little box, and that's worth 2 points. Are they a surgery patient? Do they have a chest x-ray? It's either clear or not indicated. Chronic infiltrates, and those infiltrates getting worse. Then we're going to assess the patient. What's the patient's respiratory pattern like? What's their rate? What is their mental status? Listen to the breath sounds. Can they cough effectively? And are they coughing something up with it? Are they ambulatory, meaning can they get up and move around? And how much oxygen do they need for a saturation greater than 92%? You add up all of these points on the side, and you come up with a number. In this instance, they call it a triage number. And your triage number is 5, 4, 3, 2, 1 gets assigned. Now on the other side of this assessment tells us what we're doing with that. So triage 5, we are giving medications as needed if the patient is requesting it. All the way up to level 1, where we're giving medications every 2 hours. So this makes it a lot easier for us to assess the patient in a more systematic way. And it makes it equal so that all assessments of the patient, regardless of who the therapist is, will come out with the same outcome. By following the steps in the evaluation, everyone should come out with the same number. This makes the patient-driven protocol more standardized and is based upon the care that is needed for the patient. So the key points I want you to take away from this are that it significantly improves respiratory therapy outcomes, takes some of the bias out of it, makes it more evidence-based. Appreciably lower therapy costs. Because we are not giving unnecessary therapy or unnecessary medications to the patient, this lowers the cost to the patient and lowers the cost to the hospital. And it is individualized. We can start, increase, decrease, or stop therapies on a moment-to-moment basis. As your patient's condition improves, or if your patient's condition deteriorates, you can make the decisions that are necessary to treat your patient in the way they need to be treated.